right, we are going to go ahead and get started. So welcome everyone. You should now be hearing some audio, and we're going to go ahead and start today's COVID-19 office hours. We are looking forward to spending the next 90 minutes with you all to both share some updates from our federal partners and to hear and answer all the questions that you all may have about the COVID-19 response. Next slide, please. So quick moment just about logistics, and then I will turn things back over to our team. So first and foremost, just want to reinforce all attendees are in listen-only mode, so no one is able to verbally connect with us today. But we do still absolutely want to hear from you throughout our time together. And to do that best, we greatly encourage everyone to please go ahead and to use the chat functionality today. You should see a chat icon on your screen. It's going to look like a little circle or chat bubble. If you go ahead and click on that, make sure, please, that you are clicking all participants when you are sending in either your question, your comment, your feedback, anything you'd like to share with us. If you click it to all participants, what that will do is it will let all the attendees see the comment or the question. It'll let all of us as the panelists see that as well. And so we'd love for you to do that throughout our time together today, again, to talk with one another or to raise questions specifically to the panelists. If you have a message the WebEx is trying to draw your attention to, you'll see a little orange dot on the screen, and that is your cue to go ahead and to check the chat bubble, and you will go ahead and see the chat messages there. The session is being recorded, the webinar is being recorded, and both the webinar recording as well as slides and the overview of the chat and the questions that are submitted today, all of that will be posted to the HUD Exchange, and we're aiming to do that by end of the day Monday. With that, I'm going to turn things over to Norm Suchar, who is the Director of HUD's Office of Special Needs Assistance Program. Norm? Thank you very much, Natalie. We have a packed agenda today, so I'm really quickly going to run through some introductions. We have a lot of people on the webinar today. You can see their names here, and let's go to the next slide as well. And we have some great presentations. Also want to point everyone to, we have some great domestic violence resources available today. So let's go on to the next slide, please. So the agenda, we're going to hear from CDC. We're going to get some updates from HUD. We're going to get some updates from Department of Veterans Affairs. We have some resources from the National Healthcare for the Homeless Council, and we have a special presentation on serving families and domestic violence survivors. So again, we have a lot of content, a lot of stuff going on today, so we'll just try to jump right into things. We will have plenty of time for question and answer today. But as Natalie said, please go ahead and put your questions and comments in the chat window. And if you happen to know the answer to someone's question, please feel free to also respond there. Just make sure your little send to says all participants so that everyone can see the questions. Great. So with that, I'm going to turn things over to Emily Masitis from CDC. Emily, it's all yours.
Hi, everyone. So just making sure you can hear me. Yes, great. Okay. Yep. So I am an epidemiologist here at CDC. I am on the at-risk population task force in the coronavirus response, specifically focusing on homelessness. So next slide. So I just want to give an overview right now of what's happening. I'm sure a lot of you know how many cases we've had across the country, over 200,000 cases reported to CDC as of yesterday. And we are starting to see a lot more cases and outbreaks among people experiencing homelessness. So that seems to be increasing. It's something we want to be paying attention to right now. So we're going from what we have been doing, which is lots of preparation. We should keep preparing if we're not ready, but now it's also time to think about how we're going to enact those plans. Next slide. We have two pieces of guidance up on our website. One is for shelters and service providers. The other is for people experiencing unsheltered homelessness. So please go ahead and read through those. Next slide. And we have a new tool that I want to draw your attention to. We have a simple screener for intake at homeless service provider when entry. So when people are coming in, you can use the simple screener to identify if people are experiencing symptoms that might represent that they have coronavirus. So that's when we want to start enacting those plans for where those people are going to go, how we're going to take care of them in the facility, or how we're going to link them to care. Next slide. We also have new FAQs on our website. This can help. I know that CDC, we're very good at writing lengthy text documents, especially with our guidance. So the FAQs can help drill down what we're looking for in particular, and answer some of those questions that we've been getting. And finally, we do have some more upcoming materials. We'll have flyers and posters for communicating with people experiencing homelessness, and then we will have some updates. As we learn more about the virus and about its transmission, we're going to be updating our guidance to be as up to date with the current science as we can be. So that's all from me, and I look forward to hearing your questions, and thank you all so much for being out there on the front lines and protecting your clients and staff.
Thank you very much, Emily. Next, we're going to shift things over to HUD, and we're going to hear from Marlisa Grogan from the SNAP's office. Marlisa, take it away.
Hi, everyone. Can you hear me?
Yep, can hear you great.
Great. Okay, hi, everyone. My name is Marlisa Grogan from HUD's Office of Special Needs Assistance Programs. I'm going to go over two newer resources we posted on the HUD Exchange recently, and then turn it over to my colleague, Brett Esders, to discuss available waivers for the COC and ESG programs. So we had posted in guidance on encampments, and we've received some concern from continuums of care and just general questions about the guidance or the information that we've presented, particularly about whether or not to clear encampments. We've posted an updated version of this encampments information to provide clarification, so please be sure to check back to the HUD Exchange to ensure that you have the latest version. But just to be clear, encampments should not be cleared as a punitive measure or as a public health response. So what we're hearing from the CDC and from others, and it makes a lot of sense, if people are losing contact with their case managers, with street outreach workers, that's another barrier to achieving housing stability. And it's also putting them at greater risk for infection or getting sick, and it's also putting the greater community at risk of potential virus spread. So if someone can be housed or attain housing stability from an encampment setting, by all means, that's an ideal exit from unsheltered homelessness. But if the only alternative is a crowded shelter setting, a crowded congregate setting, then it may be a better option to keep them in an encampment setting where they can have adequate spacing and sanitary facilities. And this document goes through the resources that should be available in an encampment for that to actually be a viable alternative. Next slide, please. So appropriate strategies to assist people living in encampments really needs to involve thoughtful community planning and a coordinated outreach strategy. And by that we mean offering safe sheltering options at existing shelters and safe havens, and services, food, and shelter at temporary overflow spaces. So when shelters are reaching capacity due to adjustments made to shelter operations for bed spacing and other COVID response efforts, having overflow spaces available to be able to keep sheltering people, and then isolation and quarantine space that's available based on their symptoms. Next slide, please. So another resource that we've posted is on non-congregate approaches to sheltering for COVID-19 response in the context of homeless crisis response systems. So communities may be considering non-congregate sheltering options. As I just mentioned, with shelters reaching capacity, it's important that that these overflow spaces are available. And non-congregate shelters, they can take many forms, and the guidance document that's on the HUD Exchange outlines these different forms. Continuums of care that are considering non-congregate sheltering options should reference the document, especially when you're identifying your approach and you're making staffing decisions and you're considering your target population. And another important factor that COC should consider is making sure that people experiencing homelessness are also included in non-congregate sheltering approaches so that they have a say, they can provide input. Next slide, please. So in discussing non-congregate sheltering options, it's really it's a community-based response, and it can benefit many populations, including people experiencing homelessness, but this is not only a response that's targeted to people experiencing homelessness. It's also relevant and necessary for other vulnerable populations, including the elderly, people who have underlying medical conditions, and there are other community subpopulations that would also be applicable. So if possible, identify non-congregate settings where those who are at highest risk can stay to help protect them from COVID-19, and also be in touch with your local public health department. They should be the leaders in directing placement and identifying the population that's going to be served, and also, frankly, identifying the alternate care sites, or the alternate sites that should be available. I'm going to hand it over to Brett now to discuss amendments.
Hold on, can you all hear me? Okay,
yep.
Can you hear me? Okay, cool. So right now we are you can amend your COC and your ESG grant to address some of the, some costs related to mitigating and preventing COVID-19 from spreading. You have to think within what is currently eligible or in the waivers that I'm going to talk about in a minute. And we at HUD are working on a streamlined process to expedite grant agreement amendments. So stay tuned for that. And in the meantime, reach out to your CPD field office by email if this is something you'd like to explore. Next slide, please. Okay. So on Friday, no, today's Friday. I don't even know what day it is anymore. On March 31st, we released a memo that outlines the availability of waivers for COC, ESG, and HOPWA programs. It also includes 2 waivers related to the comp plan process for all CPD formula grantees. The waiver, the listserv and the waiver say that the grantee has to provide notification to writing to the CPD field office 2 days before you plan to use the waiver. So you don't have to, right now you don't have to justify good cause in that email, you just have to send an email to the CPD field office. Each CPD field office has set up an email box that you can use to notify them that you plan on using a waiver. And you just have to keep in your files the good cause for why you needed that waiver. This is only for waivers that's in that memo, though. Any waiver that is not included in that memo, don't send to that email box. Send directly to your CPD rep, and we'll process that in the normal way, though we will try to expedite it as quickly as possible. Next slide, please. Okay, so I don't want to spend a lot of time going through the nuance. I'm just going to give you a high-level overview. For the comp plan requirements, we have waived the 30-day public comment period. You have to give 5 days notice at least. And you also don't have to follow your citizen participation plan as it's written right now. That is waived, and you can instead do another way of getting comments from your public that takes into account that public gatherings are not really a great idea right now or allowed. And these two waivers are for ESG, home, CDBG, and they go through the end of your 2020 program year. Next slide, please. Okay, there are 7 waivers for the Continuum of Care program. The first is for projects that have leasing. You can use your leasing dollars to rent a unit that is to pay for above FMR, so long as the unit is still reasonable. For permanent supportive housing projects, we recognize that getting disability documentation right now is very challenging. So we have waived so we do allow that intake workers can certify somebody's disability based on observation, and we have removed the requirement that it be backed up by third-party documentation within 45 days. So right now, an intake worker observation that's certified in the case file is enough. In addition, we have clarified that the client can also self-certify their own disability until the public health crisis is over. We have added 2 new eligible activities to housing search and counseling, and that includes paying for 6 months of rental arrears and 6 months of utility arrears. Next slide, please. We have, for 2 months, removed the requirement that you do case management for rapid rehousing projects, and we waived this in COC and ESG. We have waived 2 requirements related to HQS. One, we have waived the requirement that the initial inspection be a physical inspection, so you still do have to do an inspection before somebody moves into a unit, but you can use technology to do a virtual inspection. You could use Skype, you could use FaceTime, you could have the landlord take a video of the apartment and email it to you so that you can look at it. And we have also waived the requirement to do an annual reinspection until the crisis is over. And we have allowed you to enter into lease agreements for permanent housing that are less than 1 year, so long as the initial term is for 1 month. Next slide, please. And then there are 4 waivers for the ESG program, one of which I already talked about. The first one is a little bit nuanced, but now ESG recipients who are not the HMIS lead can pay for the costs of HMIS lead activities as it relates to updating the HMIS to incorporate COVID-19 activities into the HMIS for ESG recipients. We have said that homelessness prevention, instead of having to reevaluate every 3 months, you have to reevaluate every 6 months. And we are allowing ESG funds to be used to rent units above FMR so long as they are reasonable. That is the end of the waivers. There was a link in one of the slides and then probably in the chat. Go ahead and look at the nuances of it, and we can answer additional questions later.
Great, thank you very much, Brett. Next, we're going to shift gears to Department of Veterans Affairs. So we have John Kuhn on from VA. John, floor is all yours.
How you doing, Norm? Very good.
Good.
Next slide, please. Okay, so there are a few things I wanted to talk about regarding some of the changes we're making on what's available through SSVF. The first is that we are opening up some of the emergency housing, and I'm not sure that this slide might be cut off, but we're opening up some of the emergency housing that's available to grantees to place people who are at high risk. So we're looking at vulnerable veterans and identifying them as those folks who are over 60 or have underlying medical conditions. The capacity of VA to do this right now is somewhat limited, so we're encouraging grantees to work with local providers in the community and really helping having the VAs and local community healthcare providers help prioritize those needs. So again, this is going to be locally driven in terms of what the capacity is. We hope to develop the capacity further over time as more funding becomes available. If SSVF grantees on this call are interested in expanding emergency housing services that are available in the community and lack funds, they should contact their regional coordinator, and we will work with you to try to get you some additional funding. Next slide, please. I'm not quite sure where we are. These are not my slides.
Yeah, so I think we have to move forward a few slides.
There we go. Okay, very good. Okay, so next slide again. One more. There we go. So this one may be moot, given what Brett just announced, that the HQS is backup one. That the HQS is now no longer required. We will be able to place people in units that normally would require HQS, or because of PHAs having reduced services right now, there are some barriers to getting those vouchers in use. So SSVF can be used to hold those housing units, so hold those apartments, pay the rent until HQS is done and vouchers are processed. So there's an opportunity to make sure that landlords don't have to hold empty apartments and then, of course, unfortunately lose those apartments. It's an opportunity to fill those as quickly as possible and have some sense that that unit will pass HQS. So, Brett also mentioned the opportunity to use some virtual means. I would certainly take full advantage of that to see the unit. If it's a landlord that's known to, of course, that's also helpful as well. Next slide, please. So in these cases where SSVF is paying to hold these units, where there's some question whether HQS can be completed, and again, that doesn't sound like it will no longer be an issue, HUD-VASH staff from VA will continue to provide case management. SSVF is really just providing financial support to hold these units at this point. We do have a special referral packet that's been developed. It is available on our website at va.gov/homeless/SSVF. You can just Google SSVF, and you'll see the packet on our website. It's for those of you who are familiar with the move-in packet that's used for HUD-VASH now that SSVF supports, it's similar to that. Next slide, please. We're also expanding access to prevention. We're doing this by eliminating the Stage 2 screener for prevention services. So right now, for the rest of the year through September 30th, any prevention service can be delivered with just a Stage 1 screener. If you have to enter the score into HMIS for the Stage 2 screener, as many continuums do, I would encourage you to go ahead and still complete it, enter the score, but it does not matter what the score is. If someone passes Stage 1, you can provide the prevention assistance. We also encourage you in areas where there are moratoriums in place on evictions not to jump in immediately and pay that rent, simply because in many instances, either unemployment or other benefits that are coming from the CARES Act may make the prevention assistance not necessary, that tenant might be able to get assistance through this CARES Act and be able to pay the rent that way. But keep track certainly of folks who have presented and may be at risk, and when that moratorium is coming to an end, if there's a need for homeless prevention, absolutely go ahead and provide it. Right now, our focus, though, is if you have limited funds, and we have not made more funds available through the CARES Act yet. We do hope to be able to do that. If you have limited funds for support, I would place the emphasis on emergency housing right now, because that's where our greatest need is. And I can pass it on to the next speaker.
Great, thanks, John. And now we have your colleague, Sean Clark, who's going to present some additional information from VA. Sean, are you there?
I am. Can you hear me, Norm?
I can hear you just great.
Wonderful. Thank you very much. And I really appreciate the chance to be with you today and to tell you a bit about VA's Veterans Justice Programs, which can be a great resource and partner for you if you're working with a veteran who's justice involved, whether that's exiting incarceration in a prison or jail, as we're seeing folks doing in rapidly increasing numbers right now as communities respond to COVID-19, or veterans who are at earlier stages of involvement with the criminal justice system. The Veterans Justice Programs, or VJP in the acronym that we use, are a part of the VA homeless programs, as is John's program, SSVF, and also other programs that folks are very familiar with, HUD-VASH, Grant and Per Diem, and so on. We're considered a prevention-oriented component of homeless programs because although not all veterans who we see in criminal justice settings are homeless or at immediate risk, incarceration is the most powerful predictor of homelessness, as we've seen. So justice involvement really can put your housing stability in jeopardy, even if you're not, you don't have many other risk factors working against you at the outset. We are Veterans Justice Programs, plural, because there are two, and just to break them apart briefly, they are Healthcare for Reentry Veterans, or HCRV. This is the program in which we conduct outreach to veterans in state and federal prisons, in particular as they're preparing to exit those prisons after extended periods of time spent there. And the second is Veterans Justice Outreach, or VJO. And through that program, we work at the front end, as we call it, of the criminal justice system through partnerships with law enforcement, jails, and criminal courts, including veterans treatment courts. That's by far the most visible element of the work that goes on in the Veterans Justice Programs is what happens in veterans treatment courts, because those courts are growing so rapidly across the country and because they've gotten a lot of attention, and rightly so, over the last 10 years since they were first established. To put some numbers to the reach of these programs, in HCRV we have outreach in about 1,000 state and federal prisons across the country. That is a little bit more than 3/4 of the overall total number of prison facilities in the U.S. And on the front end, we're talking about outreach to about 1,700 local jails and 561 veterans treatment courts and other veteran-focused criminal courts. The distinction between these programs is really limited in some ways, other than the locations where specialists do their outreach work, because the goal is the same. We're partnering with criminal justice agencies to identify veterans, reach them through outreach in these criminal justice settings, assess their needs, and get them connected to responsive services as soon as possible. And we always say as soon as possible because VA is not able to provide health care to veterans while they're incarcerated. And so in the case of the prison and jail outreach that our staff do, it really is a question of planning to access services as quickly as possible once the veteran is back in the community and once again able to engage with VA health care and other services. So between these two programs, we have about 400 staff in the field across the country. They're licensed clinicians. Almost all of them are social workers by training, and they are very good people to know when you're working with a veteran who is justice involved. They're the liaisons between the VA healthcare system and the criminal justice system and the communities that they serve. And again, their focus is on helping justice-involved veterans connect to VA services. That said, it's important to be aware of a couple of important ways that the COVID-19 situation has changed things for our staff across the country, as it has for all of us to one degree or another. Prisons and jails and in many cases court facilities are closed right now for outreach purposes by and large, with a very, very few exceptions that we're hearing about. We know some courts are continuing to meet for emergency hearings or on some other greatly restricted basis, but by and large, the outreach that our staff do in these facilities has had a halt called to it. So they're not able to go in and meet face-to-face with veterans in these locations in the way that they ordinarily are and in the way that defines the work of the program most of the time. They are working with those restrictions, and in some cases they've been able to rely on telehealth connections, telephone connections, to veterans in prisons and jails in particular, just trying to find workarounds to make contact and help veterans get access to the services that they need when they come out in the community. But it's not the usual face-to-face initial encounter that we're accustomed to seeing. The second main impact that we've seen on the programs has to do with what's going on in the rest of the VA healthcare system. And so the outreach that we do in Veterans Justice Programs isn't an end in itself. As I mentioned earlier, we're trying to get veterans connected to VA healthcare and other VA services as quickly as we can. And the VA services that our staff are ordinarily in the business of connecting veterans to are radically changing their operations in response to the virus situation. So one example of this is the residential treatment programs in the VA system that are really remaking themselves on short notice to provide inpatient treatment services on an overflow basis for the rest of the system. And so they're effectively closed to new admissions. So it's a rapidly changing landscape, the VA services that our staff are able to help veterans connect to. Even with that list of options greatly constrained, I would really encourage you to make contact with VA staff who serve your community, the Veterans Justice Program staff, that is, because they can be excellent partners for helping justice-involved veterans get connected to healthcare and other VA services. So I hope everyone will have a chance to take a look at our program fact sheet. I didn't bring slides this afternoon, but we did share a fact sheet that has a brief overview of the programs and what they're for. And importantly, it also provides both of the programs' websites where you can find out a little bit more detailed information, and you can check your jurisdiction, identify the staff who serve your area, and contact them directly via the website. You can send an email to the HCRV or the VJO specialists who cover your area. Reach out that way, connect, and help see how they may be able to assist any justice-involved veterans that you're working with. So I'll stop there, just kind of a quick overview of our programs and how we may be able to be helpful, and I'll hand it over to the next speaker.
Great, thanks so much, Sean. And I just want to thank our speakers for packing a lot of information into a short period of time. And so now we're going to turn things to Barbara DePietro from the National Healthcare for the Homeless Council. Barbara, take it away.
Thank you, Norm. Really appreciate being here. I just wanted to say that as a frontline healthcare providers, we're just trying to do everything we can to protect our patients' health. And appreciate being part of this conversation. At the National Healthcare for the Homeless Council, we're just trying to provide technical assistance and other support to obviously healthcare for the homeless and medical respite providers, but other healthcare providers in the field who are doing this work. Next slide, please. Just want to make sure that folks are aware of some of the guidance and the resources that are being put out. We put this together. This is the second issue brief that we've put out, and this is in response to two needs. One need is that there is a lot of guidance that is being put together right now, particularly Marlisa and Brett and Emily talked a lot about the CDC and HUD guidance that's being created. And so a lot of this is just trying to tease through what guidance is appropriate in what different circumstances. So this attempts to do that. But the second piece, too, that we're hearing is in different communities that individual providers, either the Healthcare for the Homeless program or individual COCs or shelters themselves, are being asked to come up with the community plan for homelessness. And we really just wanted to try to illustrate, and Marlisa had mentioned this earlier, but it really bears repeating, that these are public health authorities and community authorities and your community emergency response authorities. So this is an 8-point action agenda for what the public health and emergency response systems need to be doing right now to be making sure that we have an appropriate COVID response for people who are homeless. And then this guide aligns the guidance from CDC and HUD to each of these actions. It also lists a number of strategies that different jurisdictions are currently employing to meet these issues. So just want to make sure that folks are aware of this. This is just a 3-page issue brief. If you can be using this with your state and local partners as a way of being able to guide the actions that they're responsible for doing as part of their legal authority, but doing that in collaboration and consultation with you as providers. And so just want to hit these really quick, but a lot of this has to do with isolation and quarantine spaces and how we're supporting people while they're in those spaces, how we're supporting shelters and encampments and other unsheltered locations. Obviously, the PPE and the supplies and all of that are very important, and this has been consistent across providers in all states. The transportation piece, getting to and from, again, this is a lot of thinking through what our community partnerships can look like, making sure that we're not realizing poor health outcomes just from disconnection from care as usual. So making sure that people are still able to get their Suboxone, their insulin, their blood pressure medications, keeping in touch with their therapists or their case managers, making sure people are still supported in their health care. And then finally, we're hearing a lot about difficulty accessing food and food programs, particularly as restaurants are closed and community programs are really being have a much higher demand on their capacity. So these are just some pieces. I saw links to all of this being shared in the chat. This complements our first issue brief, if you did not see that one, that outlined why this population is a priority population and a very high-risk one, and then what the policy actions are that need to happen with that. Next slide, please. Just want to, again, make sure we're trying to put together a lot of the guidance that our federal partners are putting together. Obviously, everybody's posting this stuff on pages. We're also trying to align local policies and guidance, consumer-specific materials, so that people can use those as models for what they might be doing. So if you check out our webpage here, and just want to also let you know about some of the Friday webinars and weekly town hall meetings that we're doing as part of the council. Just an hour ago, we finished a discussion about street medicine, and we will have more on that in coming Fridays. So with that, I just wanted to say thanks for being a part of this conversation and for including us. And I will turn it back over to you, Norm.
Thank you so much, Barbara, and thank you for joining these calls. You add a ton of value, and we just couldn't appreciate your participation anymore. I want to, we're going to change directions a slight bit here. We have some special content today regarding domestic violence and serving survivors of domestic violence. So I'm very, very pleased to introduce Tien Ung from Futures Without Violence, and she's going to give us a quick presentation. So Tien, thank you very much for joining us, and we're eager to hear what you have to say.
Thank you so much, Norm, and everybody. Can you hear me okay?
Yep, we can hear you great.
Fantastic. I am so grateful to be here today. I really want to thank the organizers of today's call for this opportunity. As Norm said, Futures Without Violence is a national organization that provides and aims to provide community-driven, science-based, and evidence-informed assistance to build capacity of practitioners and policymakers and leaders in the area of gender-based violence. So really grateful to be at the table today, and want to applaud the efforts that people are making on this call to pull people together, share knowledge. I think we know at the national level that what we know, we learn best from all of you who are really doing the work and feeding the insights up to us. So I think before I start, I just want to remind everybody that there really is no magic here, and that all the things that we know as service providers in the gender-based violence field about how to support children and families living under extreme adversity and violence and stress remains the same. I think what we face as a field is the issue of having our breath taken away by the constraints that we have to sort of face now that we've never, ever had to face before. The novelty of needing to think about very necessary constraints like physical distancing just changes the way we have to work, but it's also a unique opportunity for us to think about how business is done and to innovate. But there's a lot that we know, and there's a lot I bet that all of you know. I think you know lots of stuff, so let's start. Next slide, please. One of the things we all know is that stress and well-being have a very strong relationship. And these are indeed very, very stressful times. And we've been trying to encourage people to remember that not all stress is the same stress when they're thinking about solution designs and practice and policy innovation during these times. So when you're thinking about your new innovations and practice adaptations, it's really important to remember that the toxic stress, that prolonged activation of our stress response systems without any resources or supports is what does the most damage, especially to children and adults. And then there are sort of different levels of stress that is mediated by the right types of supports, by supports and resources that we can organize and mobilize that sort of lengthens, that shortens the amount of time that people have to live under distress and despair, which turns toxic moments into tolerable moments. And of course, some of the things that we often tend to forget, which we're really trying to encourage people not to forget, is that there is the experience of positive stress. These experiences are experiences and conditions that can be created and scaled very effectively. Next slide, please. So as we continue to think about the impacts of stress and traumatic stress, particularly in terms of innovation and practice design, we really want to call people's attention to the three different ways in which trauma can impact children and families who are experiencing adversity, and certainly in the context of domestic violence. And that is that the experience of violence and traumatic stress, of which homelessness is a precipitant, can get actually under our skin and affect our health. Traumatic impact can also affect our psychological wellness and our emotional well-being. It impacts how we feel, think, act, learn, and engage with others. And the effects of trauma, improperly addressed, will lead to or exacerbate major social problems like poverty, racism, sexism, crime, and disrupted education. So we want to really encourage folks to think about the new strategies and innovations that you're creating, and to ask yourself, how do our solutions promote or impede physical health? How do our solutions promote or impede emotional, mental, and social well-being? And how do our solutions promote or impede current disparities or inequities? And really think through those implications as you work collectively to try to be as responsive as possible. Next slide, please. Decision-making under current conditions really calls for us to be as proactive as possible. So another message in terms of organizing principles for design that we've been trying to get out into the field is to think about how to be proactive rather than reactive in our decision-making and solution design. And in this context, we try to offer and draw people's attention to science and evidence that tells us that there are protective factors that we can design to, especially in the context of domestic violence. And some of those are thinking about how to enable safer and more stable conditions. Sometimes you can't eliminate all the threats to violence or danger that survivors and children face, but you can make conditions more safe or more stable. Certainly focus on finding ways to make social, cultural, and spiritual connections happen for children and families. Promoting resilience and growth mindset is really important during these times to help families sustain for the long haul. Absolutely nurturing parent-child interactions is a must, and then strengthening and sustaining social and emotional abilities and capabilities at this time is also critical. Next slide, please. The science of resilience are another body of work that can also inform our resource design and our policy solutions. And in this context, we just want to draw people again to sort of the 6 components of resilience and remind folks that, again, resilience is something that's 1, common, and 2, built. It's very different and not the same thing as character traits like persistence, grit, self-directedness, risk tolerance, or cooperativeness. And when it comes to the well-being of survivors of domestic violence for children and adults, it's really important that we think about how we promote things like emotional intelligence, self-awareness. Energy is something that's really important. This is where we can't forget about exercise, health, nutrition, food, promoting those relationships, as I said. And definitely I want to zero in on encouraging folks to create solutions that help to promote children and adults' agency. Bring them into the mix and in the fold when you're designing solutions. Living under extreme conditions and adversity is something that's not foreign, unfortunately, for survivors of domestic violence. And they are resilient, and they know what solutions they need. So please bring them into the fold. Next slide, please. We were invited to sort of think about 3 questions and to just give some guidance around how to help folks like the people on the call to respond to some of these immediate and pressing concerns. So in terms of supporting families who are homeschooled in shelters, we are linking you to a fantastic website. It's called Wide Open School. It was launched about 25 days ago. It has a place for family members or educators. It's organized by grade levels. It gives you access to sort of live events, social well-being, social emotional learning tools, tools and resources and lesson plans for children who have special needs, and lots and lots and lots of ideas separated by subject. So it's a wonderful resource, and we're really trying to push people there. Apart from that, we invite people to be really realistic in setting their learning goals, right? Don't try to do a whole full school day, and instead think of like 2 to 4 hours of active learning and be creative. Give your children and your residents a chance to sort of make learning an everyday part of routines when they're brushing their teeth, when they're doing their meals. And try to make it fun at all possible, right? Focus in on writing poetry, make a family storyboard that all the residents can sort of participate in, put a big poster on the wall and have people start a story line by line, and everybody can come and add to it. And don't forget physical health as an important part of education. Next slide, please. The other question about how to support families if caregivers get ill, and especially in the context of domestic violence. Here, we're really pushing the notion of scenario planning as the key practice, with a push again for proactive versus reactive care. Really think about who your client is, who is your constituent, what is their legal status, what are their legal needs in terms of restraining orders, what are their insurance needs and medical needs, who are their social networks, what might their transportation needs be. As much as possible, try to have these conversations before somebody gets ill and have scenario plans and resources in place. Definitely do a lot of engagement around understanding what residents' social networks are, so you can proactively co-create alternative child care plans with parents. Next slide, please. Lastly, the third question that was posed to us is, how do we address the specific needs of children and families during a pandemic? And we're going to double down in these things, which I think is probably no surprise, but a good reminder for everyone on this call. Really look to identify and collaborate with local service providers to ensure sort of regular access to virtual substance treatment services, virtual mental health services, virtual advocacy services, help families access food resources, certainly fostering connections, borrowing laptops, working with your local internet service providers to increase your bandwidth so that you can help children and families video in and video chat with their loved ones and important people in their life, and help them even to connect to virtual spaces like spiritual practices and communities that might not be top of mind. We definitely wanted to put 2 plugs in for promoting fun and joy. You know, it's really easy to kind of really think about responsive crisis management, but children and families in care need fun and joy too. So get access to toys, have puzzle nights, see if you can find ways to host, you know, with proper distancing, shelter games for the whole community. And by and large, encourage mutual aid. Really turn to the residents and the constituents you serve to let them teach you about what works in their lives and what their needs are, and then you take the role of implementing to what their priorities are. Our final slide is one on resources. There are links to all of this that are just about working with children and families in shelters, and just best practices all around from the work that we've done over the years, as well as COVID-specific resources that we'd love for you to have. Thank you so much.
Thank you very much, Tian. That was fantastic. And we're now going to turn things over to Amy Torsha. Amy's from the Vermont Network Against Domestic and Sexual Violence. Amy, take it away.
Can you hear me okay?
We can hear you great. Thank you.
Great. Well, happy Friday afternoon everybody. It's amazing that we've gotten through another week. We should all take a deep breath and applaud ourselves and everybody else for that. Thank you all for having me today. The Vermont Network is our state coalition against domestic and sexual violence. I'm the Children's Advocacy Coordinator there. Been there for many, many years and have about 10 years experience working in a domestic violence. Thank you, Tien, for setting up such a great kind of introduction to where I can kind of pick up and follow up. So I wanted to just start, thank you for this next slide, with looking at some foundational themes. The first being that we all know that parenting is hard at the really best of circumstances, and stress and worry that comes with housing insecurity or homelessness or domestic or sexual violence just brings, you know, those hardships exponentially harder. For kids and families who are in shelters, in our domestic violence shelters in particular, some of this new normal is what they've already been living. So their lives are probably already upheaved, they're probably in crisis, things are probably unpredictable and temporary, and their foundations have already been rocked. And for those in DV shelters in particular, they have already had limits on their ability to move around and freely in their lives because they're fleeing violence. Sometimes with no school, and sometimes with, well, always with isolation socially. So shelters are stressful, and we know that. And the pandemic, you know, is adding a whole nother layer. And we're most likely going to see kids and parents whose stress responses are heightened, especially those who've experienced trauma. Might be hypervigilant, they might be waiting for the next shoe to drop, even if they're safe. And they may be needing help to just regulate their emotions, as we all are, I'm sure. For children and youth, it can look like acting out or acting differently or needing more attention, regressing, being clingy, irritable, crying a lot, disoriented. For adults, it can be all of those same things, regressing, clingy, disoriented, and also overwhelmed with worry about our families and money and health. And we might have shorter fuses. So for both kids and adults, you know, it's harder right now for us to regulate our emotions. I know that, you know, my heart's racing. It's hard for me to sleep. We're all up and down right now. Next slide, please. So I just wanted to introduce a really simple framework that might be helpful for you both in your work as service providers and also as information that you can pass on to parents and kids. I also want to say that I know that helping families stabilize their housing and safety is clearly the first thing on your plates, and that these concepts are something that you can use now and in the future, and they are really immediately relevant from my perspective. So we can just take a look at each one of them briefly. The first one is reassuring. So kids need to know that adults are managing this and that we're available to talk to them about it. And we can share, that they can share with us how they're feeling and how they're doing. And there are lots of resources on the internet right now, really, really great ones about how to talk to kids about the COVID-19. It always needs to be relevant to their age and stage, and the commonalities among them are generally listen to kids, all of their feelings are valid, but give them some space to really let them tell you and their parents what they're concerned about. Ask them how they're feeling, explain that the COVID-19 is a virus that can make some people very sick, but most people are okay, and that there are things that we can do to help ourselves be safe, and then to give them some power around knowing how to wash their hands and how to say hi to people with waves and how to sneeze into their elbows and things like that. Shelters, you can provide support to parents on how to best talk to their kids. You can role play with them if it's really scary for them to do this. There are handouts. There's all kinds of things. There's videos that you can share with them. You can maybe think about helping older kids by providing some tech for them so that they can still stay in touch with their friends. I know domestic violence shelters in particular are worried about confidentiality And I think right now it's time to kind of prioritize sometimes relationships and think through our roles. Let's see. We can reassure parents and kids with information that we have, like we are keeping the shelters clean and we are giving you all that you need. We're going to give you masks if you need them. We're going to stop in and give you what it is that you need. So the second one, routine. Routines are great. They give kids predictable things to count on. And even in times of crisis and even in shelters, we can offer routine. So the wisdom here is to just keep, offer to parents, see what they can keep routines that they've had. Can they keep any of them the same? They create what Sesame Street is calling for now routines with kids, that they talk about them and come up with those for now routines now and try to be consistent with those. And again, shelters can help create routines that work for your shelter environment, that are consistent and predictable for kids, things that they know they can count on, even now, even right now during this pandemic. You can offer other resources for the homeschooling piece, tech support, school supplies, quiet places, tutoring, computers, Wi-Fi. In Vermont, the kids are having a really tough time just getting Wi-Fi. I mean, they're pulling into school parking lots in cars with their laptops. Number 3, regulate. So everyone can use a little bit of emotional regulation right now. Adults can take the lead here by getting support for themselves to regulate their own emotions and by validating what kids are feeling with their emotions and helping them to calm down if they need to. And there's so much that you can find online right now that'll help kids regulate their emotions, including things like breathing exercises and yoga for teens and kids and all kinds of mindful activities. They are really wonderful, and what a great time to make that part of your routine. And shelters can ask parents what they need to support and maintain their own regulation and coping, provide art, games, play, music, writing, reading, things for cozy, comfy times, and other resources. And then the last one is relationships. And I'm just wondering how many of you are now in better touch with your friends, your families? How many of you have started a Zoom with your neighbors or your families from across the world? For me, staying connected is the highest priority. It takes precedent from my perspective over school and work. Humans need to connect through crisis, and connection creates resilience, and it helps people heal from trauma. And for many, this pandemic is going to be traumatizing. Shelters can support connections between kids and parents. They can talk about how you all, shelter workers, shelters can be helpful in keeping people connected. Next slide, please. So I just wanted to briefly let you know what's going on in Vermont. We, our DV shelters are working individually, just a lot of what Jen said, working individually with parents to come up with plans that look at, that include identifying emergency contacts for family members in case the parent becomes ill, thinking about what would happen if families become ill in a household. Can some of the other residents help with childcare? What if kids are becoming ill? Can they isolate? I think the most important message here is just that they're flexible and they're very individualized depending on the ages of the kids, the stages, what their community resources are, and how shelters are designed and set up, how many people are living in the shelter.
Amy, I think we lost you there. Amy warned me about her
but instead help them get to
tenuous connection.
Hotel or motel.
Oh, no, she's back.
Limits for shelter and hotel motel stays have been eliminated here for now, and the goal is to help people get someplace and stay there. We have congregate recovery sites for people experiencing homelessness who have COVID-19 with milder symptoms, and isolation sites for people who've been directed to self-quarantine but don't have a diagnosis, and these are individual units for each household, usually with like dormitories or motels, but with kitchenettes. They offer food and support and things like that. And this is a coordinated effort, which is led by Vermont's Agency of Human Services, and also addressing alternative care sites for a variety of other purposes. And then my last slide is just, again, some resources. Similar to what Tien offered, some of these are particularly for kids, Just for Kids, an NPR story and comic, and Sesame Street just has an incredible amount of great resources. That's all for me. Thank you all so much.
Thank you, Amy, and again, thank you, Tien. This was great content, and just thank you so much for joining our audience. We've had a lot of comments in the chat about how valuable your presentations were. So we have a few resource slides that are going to just sort of keep cycling as we go into the Q&A portion of our conversation, and we have, I don't know, like 85,000 questions at this point, so we will try to get through as many of them as we can. We also have some other people on the line that I may call on for help here. Marlisa, I wonder if you can take first crack at this question. We've had some questions about food distribution and when shelters are, or when people are having trouble accessing food or accessing meals. Can you talk about what steps, if a shelter provider or a continuum of care or just someone who cares about this sees this coming, what steps should they be taking? Marlisa, are you there?
Can you hear me?
Yep, you sound great.
Okay, great. So if you are a shelter provider or another homeless assistance provider, and you're having, and food is part of your program model, and you're having difficulty accessing it, you should be in touch with your Continuum of Care, your public health department, and emergency management officials. It's critical, even if you're not experiencing a food shortage now, but you anticipate that you might be. It's really important to loop in those partners as soon as possible. They play a part in escalating requests for assistance. So that would go to city officials, and when local resources are exhausted, it goes up the chain. So to county, to state, and then if state resources are exhausted, that's when FEMA and other federal resources can be accessed, and it's the state that needs to make that request. So I know we've heard just through federal collaboration that the USDA and others are aware of the food shortages that are going on and are working to address that. But it's important just to be really quick to make sure that leadership at the local level knows these needs, or that you're anticipating these needs, so that you can escalate your request for assistance as soon as possible.
Great. Thank you so much, Marlisa. I have a question for Brett about inspections. Actually, there have been about 25 questions about inspections. I think there's still some confusion about how the inspection process works. So can you talk about, let's say for ESG, where habitability is the inspection standard, can you talk about what can people do in this time to meet the inspection requirements, assuming they have taken advantage of every waiver we have available right now?
Sure, and Marlisa, you maybe want to stay off your mute just in case you have something to add. We didn't waive anything on the ESG program around habitability inspections. ESG doesn't require that habitability be done physically, so there's already a lot of flexibility in the ESG program to do the habitability inspection not in person. So you could do it virtually, you could do it, I think you could probably even do it by a certification checklist if you wanted, because ESG doesn't have that requirement. So we didn't waive it because there's already a lot of flexibility there.
Great, thank you. And so what did we waive on COC, and how is the requirement different than it used to be?
Right. So we did two things on COC. Right now, the current requirement for HQS on COC is that you have to, before assistance can be provided, you have to physically inspect any unit to ensure that it meets HQS standards. What we waived is that you do not have to physically inspect each unit. Instead, before assistance is provided, instead you have to visually inspect it using technology. This waiver is in effect for 6 months as of March 31st. So any unit that you provide new assistance to in the next 6 months, you have to visually inspect it, but you don't have to physically inspect it. And then once the public health crisis is over, you'll have to go back and physically re-inspect each unit that you leased up under this time. And then we waived the requirement altogether of having to conduct the annual re-inspection on COC. So when you're providing assistance under the COC program, you have to inspect each unit at least annually. And we have waived that for 1 year. So until March 31st of next year, you don't have to do the annual reinspection.
Great, thank you very much.
But you don't have to. Yes.
Great, definitely appreciate that. So we've had a lot of questions about the 2020 COC competition. And I put a quick answer in the chat box, but it's probably worth saying out loud. So the questions have ranged from why are you even trying to have a 2020 COC competition to can we just renew all the projects for a year and just try to get out of this? And I am unbelievably sympathetic to those ideas. We're looking at every option we have available and trying to figure out if we can get more options on the table. Unfortunately, I don't have anything more I can, we haven't figured this out yet, and we don't have anything we can offer yet. But what I can say is that this is something that we are paying a lot of attention to and very focused on, and that we really think COVID-19 response is the #1 priority for everyone now. And we're hoping that everyone is focused on that, and some of these other areas that are normally very important, COC governance, monitoring subrecipients, all those things that make a COC work, long-term strategic planning. We know that those things have to take a backseat to COVID-19 response right now, and so we strongly encourage you to do that and definitely support your doing that. Let's question, Brett, this is another question in your direction. There's questions about COC programs, paying staff, overtime, and hazard pay. And I know Katie answered that in the panel on the side, but can you talk about generally how that works and what the standards are for that kind of exceptional pay?
Yep, so generally, if your policies and procedures allow for you to pay things like overtime, admin leave, then you can pay your staff extra if they're working during this time. If you don't currently have crisis pay policies and procedures, then you can create them, and then you can pay using ESG or COC funds. It's important that the policies and procedures apply across your agency, not just to grant-funded positions, but you can use it to pay. And I'm sure Katie put in the chat the citation for that, but if you want the specific details, it's to CFR 200.430.
Great, thank you. And we had some questions related to when serving domestic violence survivors, and thinking about things like COVID screening, and we had some questions about how do you think about spacing in shelter programs differently? Amy or Tien, I don't know, maybe Amy, you can take the first crack at this, but do you have any recommendations for how should people be thinking about these issues, about spacing in shelters, about social distancing, about screening for COVID-19 how should they be thinking about that differently? Or should they at all be thinking about that differently for people fleeing domestic violence?
Can you hear me?
You may be on mute. Yeah, we can hear you now. Yep.
Okay, great. I guess I would just say that, again, here in Vermont, we have definitely been trying not to bring new families into shelter. And we're working with our state, collaborating with our state partners to have state-funded hotel, motel options for people who are in dangerous situations and need to have shelter. So we're not screening for people to come in so much. In terms of distancing within shelters, again, I think that shelters are taking it day by day, and so the families who are already there are there. There's no more families coming in. Staff are coming in periodically. They're talking with the families about contingency plans ahead of time, just as Tian was suggesting. What happens if one of you gets sick? And for those families who have emergency contacts where kids can go, especially if a parent has to be hospitalized, I think we would involve the state as the least amount of time as we would need to. So we definitely try to have plans made ahead that would involve family members, emergency contacts, and if somebody was isolating in shelter, they would come up with a plan for maybe residents to help care for kids while the mom is isolating. And certainly if children need to be isolated, that moms can and parents can take responsibility for isolating their kids and meeting their needs. And if there's a need, they would probably move them to a hotel or a motel as a safer option if they were really ill. And it seemed like that was the best response. And so that's how we're handling it here in Vermont. We have 15 programs. So it's not a huge number of programs.
So I'm just going to pile on to some of the wonderful things that Amy has just shared. And I'm going to take a little bit more of a global perspective because, as Amy was saying, I think every jurisdiction is really, really different. So what we've been advising folks to do who've reached out to us with those questions in terms of how to prep when someone, a caregiver in shelter, it gets sick is we are just saying get out ahead of it in terms of scenario planning. Identify the local public health specialist and medical facilities that are local to your shelter. Make sure that you know what their sort of screening practices are if residents are showing symptoms, so you can know ahead of time how to staff. In the event that a resident, an adult, or a child starts to show symptoms, and you know what sort of systems to engage in order to get testing done. We've been saying a lot to shelters about, again, doing those family social network maps. But when you're doing that, I think it's really important to remember to ask adult survivors, who are the allies in your social networks? Do they know that you are in a relationship that's unsafe? Are they aware of the dangers that are there for you? And also be prepared to provide a lot of education to family members' social networks, their friends perhaps, or their family members who can serve as alternative caregivers for their children may need a lot of support to understand what the dynamics of domestic violence are. They may need to be connected to legal advocates, local lawyers who can sort of help them establish the right safety plans and boundaries with a person who uses violence. We've been asking people to, again, be really proactive about identifying local and community resources like hotels, Airbnb-like services, and churches that can provide alternative places for isolation if that's possible. And definitely to work ahead of time to create a communication plan that can be implemented between children and parents if separation and self-isolation does need to happen because of illness. And then finally, for all of those states where COVID hasn't yet exploded, stock up on supplies, cleaning supplies, fever-reducing medications, that type of stuff. But we also try to remind people that you know, the severity of COVID when somebody gets sick is very, very variable. So partner with your local medical authorities and design according to the severity of the symptoms.
Great, thank you. That's great information. And I think in the chat box, I will say some people were asking about forms that Amy was talking about, family plan forms, and Amy agreed to share, and we'll try to post that the link to that when we post the recording of the webinar and the slides of the webinar. So we will be posting probably early next week the video of the webinar as well as the slides independently. Also, Natalie, I think a couple times has shared the instructions for if you just want to copy and paste the entire chat window. There's a lot of great content in there. There's a couple questions about sheltering in place orders and the guidance we have about encampments and about not forcibly moving people out of encampments. Marlisa, I'm wondering if you could talk a little bit about how people should be handling encampments in communities where they have shelter-in-place orders, or some of the states that have enacted stricter guidance on sheltering in place than some other states. Do you have any sort of thoughts or information for us?
Hi, can you hear me?
Yep, can hear you great.
Okay, great. David Canavan, our TA provider, is also, he's very knowledgeable in this area, so David, please feel free to jump in. But my initial thoughts are that, shelter-in-place orders and how they're enforced can really vary from state to state. So I don't think that there's a universal response as far as that goes, just because the parameters may and the legal aspects of it may really differ. But when it comes to sheltering in place and our encampment guidance, it's really thinking through the conditions that are safest for the people residing in an encampment environment. So if you have an encampment where there are portable toilets, hand washing stations, portable showers, a stable access to food and wellness checks, if you have stable street outreach, availability, and the ability to enough space to be able to provide adequate social distancing and distancing between tents. Those are all conditions that would make an encampment not a preferable option, but potentially a safer option than a congregate shelter setting. So in that sense, it would be advisable to keep people residing in encampments there as opposed to moving them around and exposing them to higher risk of infection. David, do you have anything else to add?
No, I think you hit all the right parts.
Great, thank you, Marlisa and David. So I want to take a minute out to talk about the waivers that we've issued and CARES Act funding and other things, because I just wanted to be clear that we've issued a set of waivers for emergency solutions grants, for Continuum of Care programs, and for housing opportunities for people with AIDS programs, people with HIV/AIDS, HOPWA programs. But that's not the end of the flexibility and waivers and alternative requirements that we'll be publishing. For weird, this is just the way the federal government works reasons, there are different ways that you do different authorities and different waivers. So getting this waiver out was the easiest thing to do very quickly. So we did that, we got that out first. But we're also working on additional guidance related to the ESG allocation. So you'll see some more flexibilities coming from there. And we're also looking at other possible waivers or alternative requirements or other things we can do. A lot of you have suggested different things we could waive. I will say some of them are things we would actually need Congress to act upon, but some of them are very, very good suggestions. And so please keep those coming. We really try to think of everything we can, but we just don't get everything in the first try. So please keep making suggestions. We also had a question about the mega waiver about, is there a reason that COC recipients were not required to include their COC in the request to the field office regarding the waivers, or in the notification to the field office? So I want to address this. Seems like a minor technical thing, but I want to address this because, like, there's nothing we value more than the partnership with COCs and recipients, and we definitely see all of us as partners together on this work, and not we're not trying to leave anyone out of the process. But we also recognize that there are a lot of COCs that are really struggling to keep up with what's going on, so we didn't want to create a situation where there was a lot of burden on COCs, or where a COC just not being able to respond would slow down some activities that were really important. We definitely strongly urge, whatever the strongest version of that is, for recipients and COCs to be working together on this. And we really encourage COCs to just work with the recipients and combine all the waivers or combine all the requests into one sort of giant request, and to coordinate as much as possible. But I just wanted to be clear that we weren't sort of trying to keep anybody out of the process. We just wanted to recognize that it's a difficult time for everybody. Communication can be very difficult, and we didn't want to slow things down, but we definitely want to encourage that level of cooperation and coordination. Brett, I want to turn this next question over to you as well. We had some questions about the disability documentation and when things go into effect. So when can they start using the sort of alternative disability documentation? This is for COC programs. Does this apply just to dedicated projects? Well, let's take these one by one. When can they start doing this?
So if this is a waiver that you need, you have to email the special inbox for your CPD field office. And as soon as you do that, alerting them that you're going to use it, you can use the waiver 2 days later. Calendar days, not business days.
Great. And then, and is this just for dedicated chronic homelessness projects? Is it for all permanent supportive housing projects?
It's for all permanent supportive housing projects.
Great. And so at the end of the waiver, after the waiver is no longer there because the time has gone on, do we have to go back and document disabilities for those individuals who were housed under the waiver process, or can they just stay and you don't have to redetermine disability?
You do not have to redetermine disability. Basically, for anybody housed during this time frame, that is the acceptable disability documentation.
Okay, great. Those, I think, were the main questions we had along that line. But I think it's really helpful to get clear these things up as much as possible.
Maybe
so we
people
had.
Didn't believe we were that lenient.
Well, So we had a couple questions about sources, and Marlise, I'm wondering if you can address this question. We had a couple of questions about sources of funding for hotels and motels. Some of them were related to serving domestic violence survivors. Some of them were related to people. Sorry, I got a little off track. Someone was congratulating us for being flexible, and I just appreciate it. Thank you. So some of them were related to domestic violence survivors. Some of them were related to shelter decompression. But there's clearly a need for hotels and those kinds of resources. Somebody in the chat box also mentioned college dorms. So we know that FEMA can, in some cases, pay for these things. We know that ESG can pay for these things. So if you're in a community and you're trying to organize all this stuff, how would you be thinking about this? What guidance would you give to to community leaders who are trying to figure out, okay, there's all this money from different places. How should I think about how to organize this stuff?
Sure. So if you are a shelter provider or you're recognizing that a shelter in your community is or will quickly reach capacity, and you're thinking about shelter overflow spaces, it would make sense to, and in all cases, you're going to try to access local resources and local funding first, because before you access FEMA funding, you really need to exhaust all local resources. So if you're talking about shelter overflow, you'd want to explore ESG funding. ESG hotel motel vouchers are available when there's no other shelter available, and we would certainly consider hotel and motel vouchers eligible if you technically had space in your shelter, but you wanted to be able to provide a quarantine or isolation space for someone. We'd consider that shelter not being available because you want to provide that safe space for both shelter residents who are in the shelter as well as those who may need isolation or quarantine space. So definitely ESG, and then once your local resources are exhausted, that's at the point where you want to reach out to your county and then state and then try to access FEMA resources when local resources are exhausted. It's also important to differentiate between shelter overflow for people who are healthy and they just need space and your shelter is full, and alternate care sites, which could take the form of, a dorm room or a hotel motel space for people who are COVID positive or who are symptomatic or are waiting test results, because that's not entirely on the homeless crisis response system. Public health and emergency management officials are really in charge of providing a community-wide response, not just for people experiencing homelessness, but also for other community members. So it's not all on you. As Barbara really aptly pointed out and reminded us, it's those spaces should be funded and organized, with a community-wide response. So if you find that you need those spaces to be able to shelter people who are symptomatic or COVID positive, then you should be reaching out to public health and emergency management.
Great, thank you. Appreciate the thoughtful response to that. So we're at the end of our time now. I just want to thank everyone. We've stuffed a lot of content into that 90 minutes. I want to thank everyone, thank all our guest speakers, and thank all the participants on the call. The chat box was great today. Thank you for people who chipped in and helped answer other questions in other communities. And we will be doing this again next week. Definitely heard that it's helpful for us to be able to answer as many of the questions as we can. So we will take a look at options for making sure we can answer even more of the questions. All this content will be available early next week. And stay signed up to our listserv, or if you are not signed up for our listserv, please sign up so you can be getting information. For example, we have a daily digest that's going out every morning with new resources that we've published the previous day. So again, want to thank you all for joining, and that concludes the webinar. Have a great day, everyone.